بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. اللهم اجعلنا ممن يستمعون القول فيتبعون أحسنه وأدخلنا برحمتك في عبادك الصالحين. Dear colleagues, we'll start the second part of this topic, which will deal with the imaging of metabolic bone diseases. And in the previous lecture, we have finished the issues of osteoporosis, osteomalacia, rickets, hyperparathyroidism, as well as the renal osteodystrophy. And you remember we have sub-items in the topic of osteoporosis: the systemic type, the regional type, the migratory osteoporosis, and the reflex sympathetic dystrophy. Now we'll cover the rest of the topics, starting by scurvy, which is a disease caused by the lack of vitamin C in the diet, and this will result in increased bleeding tendency, and sometimes the patient suffers from osteoporosis and impaired wound healing. As you all know that the human body cannot produce their own vitamin C, and the only source for vitamin C is the intake through food, and this will the deficiency of vitamin C may result from inadequate food intake, which is rich in vitamin C, or absence of fresh fruits in the diet. And also vitamin C is very friable and is destroyed by cooking and canning. And the result of vitamin C deficiency is the bleeding, which occurs at many sites, including, of course, the skin and other parts of the body. But we are interested here in the skeleton, and there may be bleeding inside the joint and bleeding in the supraosteal area, leading to periosteal elevation. And some of the well-known signs, like Weinberger ring sign, which indicates that the epiphysis has a well-defined sclerotic rim, and the Franklin line, which means that there is an area or a zone of sclerosis in the terminal part of the metaphysis, and also the Bilkin spurs, which are protrusions near the site of the joint due to the elevation of the periosteum. And here are the signs of scurvy in the skeleton, including the supraosteal hemorrhage and the Franklin line, the Bilkin spur, Weinberger sign. And actually, we do not usually see scurvy in our clinical practice nowadays, but you may meet this in the exams, for example, and you can easily appreciate the presence of periosteal elevation and due to supraosteal hemorrhage and the spurs at the metaphyseal ends of the long bones, as well as the sclerotic rim surrounding the epiphysis. And here also you can see some decrease in the bone density, and you see the sclerotic area, and also you see the spurs, and you can appreciate the sclerotic rim around the epiphysis. Then we shift to another one of the commonly seen metabolic bone diseases, which is gout. And this is one of the types of crystal arthropathies where there is the position of ureate crystals inside the joint and around the joint. And this disease usually occurs in patients above 40 years with a strong male predilection. There are five stages of gout, which include the asymptomatic hyperuricemia, high uric acid level in the blood without any symptoms, acute gouty arthritis, interictal gout between the acute attacks and the chronic gout, which is characterized by tophaceous formation or the formation of tophi, then the gouty nephropathy. And here are the risk factors for the development of gout: obesity, hyperuricemia, alcohol intake, myeloproliferative disorders, chemotherapy, hyperparathyroidism, and thiazide medications. And this hand X-ray shows typical appearance of gouty arthropathy in the interphalangeal proximal interphalangeal joint, where you see erosive changes away from the joint line associated with abnormal soft tissue swelling surrounding the affected area, which is related to the formation of tophi. Then gout may have a latent period between the onset of symptoms and the appearance of bone erosions. And gout may have a predilection for the small joints of the hands and feet. And you know that the metatarsophalangeal joint of the big toe is one of the preferable sites for gout. Also, calcium may occur in the cartilage, leading to chondrocalcinosis in about 5% of the cases. Joint effusion may occur. The joint space is preserved until late in the disease, as the erosions are usually juxta-articular, not affecting the articular surface until late. And there is absence of osteopenia in the early phases of the disease, where you can see this very characteristic erosions, which are known as the punched out or overhanging erosions with overhanging edges, which are the one of the characteristics of gout erosions. Also, the deposition of crystals in the juxta-articular area may occur in some of the bursae, like the olecranium bursa, for example, leading to the soft tissue mass, which may show some calcium and may be associated with erosive changes. Then, as any disease in the MRI, the appearance will be iso intense in the T1, and they may show some increase in signal in the T2, or if there is calcium, you see hypointensity. And if you inject the contrast material, the tophi will enhance. And this is a patient with gouty arthropathy in the hand and elbow. You see the distension of the olecranium bursa by soft tissue mass due to tophi, and many soft tissue swellings around the joints of the hands without any apparent bone erosions, except for this erosion in the ulnar styloid process, and also some erosions here in the proximal interphalangeal joint of the index finger. And here you see one of the common sites for gouty arthropathy, where it affects the metatarsophalangeal joint of the big toe, and other joints are also affected, showing the classic extremely or sharply defined erosive changes with characteristic overhanging edges. And here is a limited X-ray of the foot, showing classic appearance of gout in a classic situation where it affects the metatarsophalangeal joint of the big toe, and also the distal interphalangeal joint of the second toe. Here is juxta-articular erosions, which are sharply marginated with overhanging edges, simulating the rat bites. And joint space narrowing occurs very late in the disease, Bone sclerosis also occurs late, and soft tissue swellings and days to 5 may show calcium. Then you came to the calcium pyrophosphate dehydrate crystal disease, and this disease may be idiopathic or hereditary or secondary to other metabolic abnormalities like hemochromatosis, hyperparathyroidism, hypothyroidism, and hypomagnesemia, previous joint injury, previous trauma, and also in cases of ochronosis, I will mention in a moment. And this disease results in the deposition of calcium in the cartilage, what's known as chondrocalcinosis. And this uh, deposition has a predilection for the knee in particular, and also in the wrist, and can be in the spine around the odontoid process, as well as in the intervertebral discs. Then you can see secondary to deposition of the calcium in the cartilage, disturbance of the joint function leading to osteoarthritis in the shoulder, in the elbow, in the wrist, and also in the patellofemoral joint. And this is an example of pseudo gout, or let us say this chondrocalcinosis, because the chondrocalcinosis will be termed pseudo gout if there are acute symptoms only. But this disease is usually asymptomatic and is seen commonly in elderly patients. You can see calcium in the meniscus, and also you can see calcium in the articular cartilage, for example, and you appreciate the presence of osteoarthritic changes. And here is the calcium dihydrate pyrophosphate deposition disease, where calcium is deposited in the articular cartilage and joint capsule, and, and here you see uh, calcium in the menisci, and calcium in the hyaline cartilage, and maybe calcium in the tendon of the gastrocnemius muscle as well. In the spine, calcium may affect the annulus fibrosus and the transverse ligament around the odontoid process. Also, the supraspinous and intraspinous ligaments may be affected. The intervertebral discs, the longitudinal ligaments, deposition of calcium may lead to spinal canal stenosis. Then the calcification of the transverse ligament around the odontoid process may result in this appearance, which is known as the crown dens. And here is the manifestations of the disease in the spine. You see calcium in the anterior longitudinal ligament, for example, and you may appreciate calcium in the interspinous ligament as well. In the knee, calcium is deposited in the menisci as well as along the articular cartilage covering the condyles. In the wrist joint, calcium is deposited in the triangular fibrocartilage and may also affect the scapholunate ligament and the lunotracheal ligament. Then we came to the disease known as ochronosis, and this is an autosomal recessive metabolic disorder. And this disorder will result in accumulation of homogenistic acid in the soft tissues and the cartilage, resulting in early degeneration of the cartilage and the calcification. And this may affect the spine and other parts of the body, resulting in a disease simulating advanced spondylosis of the spine. But if you look to the patient age and you see that the age is in the range of 30 to 40 years, which is far young for these changes in the spine. And this is the way where the disease happens. autosomal recessive condition resulting in lack of homogenistic oxidase, and this will result in excess homogenistic acid in the collagen in the connective tissues. Then the connective tissues becomes weak and brittle, leading to inflammation, degeneration, and osteoarthritis. Where here in the spine is a severe narrowing of the intervertebral discs as well as interdisc space calcifications. And this is uh, lumbar spine of a patient with ochronosis. You see the extensive degeneration of the intervertebral discs, the presence of calcium, the presence of vacuum phenomena. Then you should know that the apophyseal joints are not involved, and also the Mamdouh spine is not seen, so that you can easily differentiate between this disease and the spondylosis, and also differentiate this disease from ankylosing spondylitis. The radiological findings in the spine of this ochronosis include severe osteoporosis, narrowing of the disc spaces, calcification of the discs, marginal osteophytes, and thin desmophytes, which are the osteophytes crossing the disc to the opposite, to the above or below vertebra, vacuum phenomena, air in the disc spaces, kyphosis, and scoliosis. And here you can see extensive degenerative diseases in the spine with severe narrowing of the dorsal and the lumbar intervertebral disc spaces, calcium within the discs, and the vacuum phenomenon. And you remember that ochronosis is one of the causes for chondrocalcinosis. This is once more a male patient, 42 years old, with severe degenerative changes of the spine and calcification of the intervertebral discs. Now we came to the acromegaly, which is a disease occurring due to excessive production of the growth hormone after skeletal maturation. And the most common cause is usually an adenoma in the pituitary gland, seen in about 90% of the cases, while the remaining 10% of the cases may result from tumors of the pancreas, lung, or adrenal gland, and these tumors may release the growth hormone. Then the excess growth hormone will be reflected on the skeleton, and there are characteristic appearances for patients with acromegaly, which is which have features pathognomonic for this disease, like the calvarial thickening of the bones of the skull, enlargement of the sinuses, especially the frontal sinus, enlargement of the sella turcica due to the presence of this adenoma, broganthic jaw, protrusion of the mandible, hypertrophied terminal phalanges, and the spade phalanx sign I will show, and in joint space widening, premature osteoarthritis, and increase in the thickness of the heel pad of fat. Then the complications of acromegaly may include the presence of severe headache, arthritis, carpal tunnel, cardiomegaly, hypertension, diabetes, heart failure, renal failure, and visual disturbances. This is the classic appearance of acromegaly in the hands, which include about five manifestations. Number one is generalized enlargement of the hand itself. Number two is prominence of the phalangeal tufts showing the mushroom-shaped appearance. Number three is widening of the metacarpophalangeal joints. Number four is the presence of metacarpal hooks. And if you look carefully, you see that each metacarpal has a prominent what looks like a hook in its distal end. The same manifestations are seen in the foot with prominence of the phalangeal tufts and widening of the metatarsophalangeal joint, and the metatarsal hooks are also prominent, together with generalized increase in the size of the foot. And if you measure the heel bed of fat from the undersurface of the calcaneus to the skin, it will be increased more than 2.5 centimeter. This is one of the manifestations of acromegaly. Paget's disease is one of the diseases of unknown etiology. It is thought to be due to viral infection with genetic susceptibility, and it has well-known three stages: the lytic active phase, the mixed, which includes lytic and sclerotic lesions, as well as the sclerotic or the blastic late inactive phase. This disease is seen in about 4% of the individuals over the age of 40 and about 12% of individuals above the age of 80. There is a slight male predilection, and this disease is considerably high in UK than in other countries, according to the literature. Most of the patients are asymptomatic, and if there are symptoms, they may include pain and tenderness, local hyperemia due to increased blood flow to the affected bones, increased size of the bone, deformities, and kyphosis of the spine. And one of the appearances which is characteristic to the skull of a patient with Paget disease is this dam or shunter hat, which means that there is a curve in the frontal bone simulating this hat because of the considerable enlargement of the size of the skull, as I will show. Then osteoporosis circumscripta, meaning that there are areas of osteolysis affecting the calcareal bones. The cotton wool appearance will result from or will be seen in the mixed phase where lytic and sclerotic lesions affect the skull, together with the diploic widening, as you can see here. Here there is marked diploic widening of the space between the inner and outer tables of the skull. Then by enlargement of the skull, it will protrude like this, forming the simulation to this hat sign. And also you can appreciate the presence of sclerotic and osteolytic lesions in the calcareal bones. And this patient is assessed for acute hemiparesis. The X-ray of the skull showed appreciable thickening of the calcareal bones, some osteolytic lesions, some areas of sclerosis, and of course these lesions will be more evident on the CT scan. And whenever we talked about the spine, and we have mentioned that if you are faced by a solitary sclerotic vertebra, then the differential diagnosis is one of three. Either this is lymphoma or metastatic deposit or Paget. And you can assess the possibility of Paget if you appreciate that the vertebral body size is more than the size of the above vertebra or the vertebra below, because one of the major criteria of Paget disease is enlargement of the bone. And here is a case of Paget affecting 5432 L2 vertebral body. And you see that the vertebral body is enlarged with coarse trabecular striations, and the disease also affects the neural elements as well as the spinous process compared to the above and the below vertebral bodies. And this is the difference between sclerotic metastasis with no significant change in the size of the affected vertebra compared to that above the above or below vertebrae, while in Paget disease you can appreciate the sclerotic vertebra is larger than the vertebra below or the vertebra above. Also, Paget can affect the pelvic bones, and it will result in the same manifestation: gross enlargement of the affected bone, coarse trabecular pattern, and this may be unilateral, affecting half of the pelvis, or maybe bilateral, affecting both iliac bones, including the pubic and ischium as well. Then one of the criteria of Paget disease by bone scan is what's known as the super scan, where the affected the bone with Paget disease will show metabolically active areas with very high tracer uptake, and this may help together with the other imaging finding to diagnose Paget disease. And this is bilateral Paget disease of both pelvic bones, affecting the pubic and ischial bones, as well as the iliac bones, together with affection of the left femur, the proximal left femur, together with bilateral osteoarthritic changes. According to the literature, one of the criteria of Paget disease in the long bones is what's known as the blade of grass appearance. And this means that if you look to this blade, it becomes narrower as you go to the periphery. And if you look to the lesion of the or the affected part of the bone by Paget, and you see that the edge is almost similar to the blade of grass. And this is not, of course, an important sign, but is just a finding, because you don't need help to know that this is Paget disease of the femur, guided by the enlargement of the size of the bone and the increase in the trabecular pattern. And one of the findings by MRI is that bones affected by Paget disease preserve their fatty bone marrow signal, unless there is another complication of Paget, like the development of infection or the development of fractures or the development of sarcomas. And look here, this is CT scan of the pelvis affected by Paget disease with gross enlargement of the sacrum and the iliac bones with obliteration of the sacroiliac joints. The same manifestations are seen in the spine. What's important here is the sagittal T1 weighted image MRI shows that the vertebrae affected by Paget will preserve the normal marrow signal if not complicated. The complications of Paget will include a weakness of the bone resulting in fractures and deformities. The abnormal enlargement of the bone will disturb the joint function, resulting in the development of osteoarthritis. The changes in the skull may encroach on the skull base foramina, resulting in cranial nerve pulses. Also may disturb the hearing function. Basilar invagination may occur due to skull base softening. Hydrocephalus or brainstem compression also due to basilar invagination. And one of the known complications is the development of sarcomas on top of Paget disease, especially the osteosarcoma, and due to the high blood flow in the bones affected by Paget, patients may develop congestive heart failure, and one of the complications also is hyperparathyroidism. And this is once more the blade of grass appearance. If you look to the bone, there is gross enlargement and coarse trabecular pattern, and you see the blade of grass appearance. But you can also appreciate this sun ray speculation, which means that the patient had developed an osteosarcoma on top of Paget disease. In Gaucher, one of the metabolic lesions that results from deficiency of glucocerebrosidase cerebrosidase activity, and this will result in accumulation of glycolipids within lysosomes of macrophages, particularly in the bone marrow, in the spleen, and in the liver. There are two main types. The type 1, which usually presents in adulthood, but some patients may see the disease may appear in the children. Skeletal symptoms like bone pain, pathologic fractures, and one of the pathognomonic features is the development of osteonecrosis due to vascular occlusion by the Gaucher cells, and due to deposition of the cells in the liver and spleen, significant hepatosplenomegaly may be seen. The type 2 is an infantile type which presents by the age of 6 months, leading to progressive neurological deterioration and death by the age of 1 to 2 years. One of the radiologic features peculiar to Gaucher disease is what's known as the Ellner-Meyer flask deformity, and this is the Ellner-Meyer flask, where you can see the bone is the normal bone remodeling is absent, and the distal part of the bone is expanded, and in the proximal, like the distal part of the femur, proximal part of the tibia, almost similar to this the flask appearance. Then you may see fractures, as I have said, and you see also H-shaped vertebra, and this is due to ischemia in most of the cases. By bone marrow, by MRI, they see abnormal bone marrow signal due to deposition of the Gaucher cells within the bone marrow. And these patients usually have massive splenomegaly and consequent splenic infarctions together with hepatomegaly and areas of inflammation, fibrosis, and infarction. Then the manifestations of Gaucher disease by MRI is a loss of the normal bone marrow signal on T1 and T2 weighted images, and also the presence of osteonecrosis due to occlusion of the blood vessels leading to certain areas. And if you look here to the spine in this T1 and T2, and you can see the reduction of bone marrow signal in both T1 and T2 relative to the intervertebral disc spaces. Then we came to the osteogenesis imperfecta, which is a metabolic disease due to congenital genetic disorder of collagen type 1 production. And this collagen type 1 is a major constituent of bone and dentin, the sclera, ligaments, vessels, and the skin. The incidence of this disease is somewhat like 1 to 2 to 13,000 births, and the hallmark of the disease is osteoporosis and fragile bones. The blue sclera is one of the intimately or peculiar findings in this osteogenesis imperfecta. The sclera is blue, and there are dental abnormalities and also hearing abnormalities. Then we have many types of osteogenesis imperfecta, but the well-known types in the clinical practice are three. Type 1, which is a mild disease. Type 2, which is a prenatal lethal disease. And type 3 is a progressive deforming disease. The major clinical features are osteoporosis, bone fragility, sclera that is blue, then tegenesis imperfecta on abnormalities in the teeth, and hearing impairment. And other features may include ligamentous laxity, hypermobility of the joints, short stature, and easy bruising. This is type 1, which is the most common. The collagen is normal, but the amount is less than normal. Then you see that the bones are fragile, they fracture easily. Most fractures occur before puberty. The stature of the patient is almost normal. The joints are loose and the muscles are weak. The sclera is blue. This is important. And the face is triangular in shape like this. Mm, Actually, you may not see bone deformities. The teeth are abnormal and the hearing is also abnormal, and you can find deafness by the age of 20 to 30 years of age. The type 2, which is the most severe, the collagen is improperly formed, and this disease occurs in utero. The patient suffers from respiratory problems and so many fractures and bone deformities. The stature is small with underdeveloped lungs, and uh, this is the appearance of the type 2 osteogenesis imperfecta with short beaded ribs, um, then concertina long bones, multiple in utero fractures, and poorly ossified calcareal bones. And this is type 2. You see the striated appearance, the deformities, the fractures, and in type 2 osteogenesis imperfecta. Type 3, the fractures are present at birth, and this is the collagen is also like type 2 improperly formed. The patient is so short in stature, the sclera is blue, the joints are loose, and there is barrel-shaped rib cage, triangular face, spinal curvature and kyphosis, respiratory problems, bone deformities, and the teeth and the hearing are also involved. And this is osteogenesis imperfecta with severe deformities of the bones of the upper limb, as you can see. And this is skeletal deformities in an osteogenesis imperfecta with multiple fracture lines, bilateral and almost symmetric. And this is also a case of osteogenesis imperfecta. The bones are osteoporotic, they are deformed, and you may see some fractures. Finally, we came to the osteopetrosis, which is an uncommon hereditary disorder resulting from defective osteoclasts. This will result in increased bone density, and the bones are actually sclerotic, but they are very weak and fracture easily. There are two separate subtypes of osteopetrosis: the infantile autosomal recessive type and the benign adult autosomal dominant type. Both forms are congenital with localized chromosomal defects. And this is the infantile type, which presents by facial premature senility, dental caries, anemia, leukocytopenia, thrombocytopenia, cranial nerve compression, hepatosplenomegaly, lymphadenopathy, and some other lesions in the kidney, and the cerebral calcification, subarachnoid hemorrhage. This is important finding. Prognosis of this disease is relatively bad since most of the patients do not survive beyond the middle age, and death usually occurs from recurrent infection or massive hemorrhage or terminal leukemia. And here you see generalized increased bone density of the whole skeleton with loss of corticomedullary differentiation, and you can see some bands of translucency, and many times also you can see the Erlenmeyer flask shape configuration in the affected bones. And here is osteogenesis imperfecta with one of the pathognomonic finds, which is known as bone within a bone. And you can see it in the metatarsal bones with generalized decreased bone density. And the bones are brittle and easily fractured near bilateral fracture of the upper femur, which is internally fixed. The benign adult type, which is an autosomal dominant, about 50% of patients are asymptomatic, but they may suffer of recurrent fractures and some anemia with cranial nerve pulses. And the X-ray, you'll see diffuse osteosclerosis, increased bone density, cortical thickening encroaching on the medullary cavity, Erlenmeyer flask deformity, and the long bones, bone within a bone, as you see, uh, sandwich-like vertebra, indicating fluctuant course of the disease, metaphyseal striations, the mandible is the least to be involved, and the prognosis is somewhat good. This is an example, female 30 years old with increased bone density and some kyphotic deformity of the dorsal spine, but the overall appearance of the skeleton apart from bone sclerosis looks normal. هذا وبالله التوفيق والحمد لله رب العالمين. Thank you.